So, hello and welcome everyone. My name is Dr. Brian Hill. I'm the director of the Lymphoid Malignancies program at the Cleveland Clinic, Taussig Cancer Institute. On behalf of the CLL Society, we are conducting interviews of authors who presented important findings on CLL research at the most recent American Society of Hematology annual meeting, which was held in December of 2024. So I'm pleased to be joined by Dr. Laura Eurlings. Dr. Eurlings, would you like to introduce yourself?
Yes, thank you so much. Thank you for inviting me. My name is Laura Eurelings. I'm a doctor and a postdoctoral researcher at the Department of Hematology in the Albert Schweitzer Hospital in Dordrecht. And there I did the research that ultimately was presented at the ASH meeting.
Excellent. So the presentation that we're going to be reviewing was entitled Quality of Life in Patients with Relapsed Refractory CLL Improves After Minimal Residual Disease Guided Treatment with Ibrutinib plus Venetoclax. So perhaps you could kind of share with the audience what the question was and what the study, how the study was designed and what the findings were.
So the rationale behind the study is, of course, that CLL often presents itself in patients with more advanced age. And for most patients, it's, of course, a chronic disease. And therefore, we want to look into not only treatment success, but more so what is the effect of treatment on the quality of life. And for some therapies, we already know something about the quality of life. For example, venetoclax monotherapy improves quality of life, as well as ibrutinib monotherapy. But we did not know yet what the combination therapy had for an effect on the quality of life. And that is why this study was designed. So it is a study that is done within the HOVON 141 trial, in which patients were treated in an MRD-guided manner with ibrutinib and venetoclax. And within this system, patients were randomized based on their MRD status, and they did receive 15 cycli of both ibrutinib and venetoclax. And after that, based on their MRD status, they went on with ibrutinib if they were MRD positive, and if they were MRD negative, patients could be randomized to stop the ibrutinib or continue ibrutinib.
So after 15 cycles of combination therapy as opposed to monotherapy with both ibrutinib and venetoclax, after 15 cycles, so a little more than a year of treatment, what proportion of patients had undetectable minimal residual disease?
Unfortunately, not the majority. So the majority of patients went on to have ibrutinib
Continuation of treatment.
Yes, and
Yeah.
I think in the end, 24 patients were MRD negative and were continuing ibrutinib, were randomized to that arm, and 48 of patients were MRD negative and were randomized to stop ibrutinib.
Mm-hmm. And so, what were the metrics that you were using to study quality of life in the patients on the study?
Within this framework, quality of life questionnaires were assessed. So it was both the QLQ-C30 questionnaire, which is a cancer questionnaire and is often used in quality of life research. And this was supplemented with the QLQ-CLL16 questionnaire, which is, of course, a CLL16 CLL-specific questionnaire with 16 questions regarding CLL. And
these cover domains of mental health, physical well-being, and so forth.
So the C30 has two large parts. stage, which is one, the functioning. So there we look at emotional functioning, physical functioning, but also role and social functioning, and a global health status metric. So how are people feeling and how are they feeling about their own health? And we also have symptom scores within that questionnaire, and these symptoms are ranging from fatigue, diarrhea, dyspnea. All these symptoms are part of the questionnaire.
I see.
So,
And
and
what were
these
your
questionnaires
findings?
were given. These questionnaires were given at baseline to patients, and then after the induction treatment with Ibrutinib-Venetoclax, and then at 6 months later, and then 6 months again, and then at 1, 2, and 3 years after end of induction treatment. And one of our most important findings was that the global quality of life improved after the 15th cycle of Ibrutinib and Venetoclax. So the majority of patients had an improvement, some patients had a stable global health, and only a few patients, around 15%, saw a deterioration of their health status after treatment.
And was
And
there
when we
any association with the dose of ibrutinib? Because we know that ibrutinib can have various side effects, arthralgias, diarrhea, and so forth. Did you see or have you been able to examine dose levels with quality of life assessments?
Fortunately, we were not able to really look good at the dose, but what we did do is look at the adverse events and also what was registered as adverse events within patients, and we saw that the diarrhea scores correlated with the adverse events. So that's good that you know that you're picking up the same thing with both what the patient experiences, but also what the provider reports as an adverse event. And what was also interesting to see is, of course, for the most part, the global health status improved, the fatigue was also improved, the dyspnea improved, but after induction treatment, we did see also more diarrhea symptoms, which we expect with the treatment.
Mhm.
However, if we look 6 months later, then you saw the diarrhea scores decline again. So we think that's partly due to some patients stopping with the ibrutinib based on their randomization, but also patients maybe also getting a little bit more used to the ibrutinib, and then the symptoms also going down to before treatment baseline
Sure.
levels.
Yeah, that makes sense. So I think it's an important part of the kind of the research that is being done on the field, and I commend your group for doing this because so often we focus on things like progression-free survival and overall survival. And I think one of the things we've heard pretty clearly from patient groups is that of course they want to survive, that's first and foremost, but they also want to live healthy, functional lives with good quality of life. And I think it's reassuring to see that combination treatment can, very objectively, as you demonstrate, improves those parameters. So, what do
Yeah,
you
and we
sort
can
of
also
see as next in future? Where do you see this research coming next in the future?
Well, I do think that's really important to look at quality of life, but also look at it in a standardized way. And of course, this study was performed within the Hoven group in collaboration with the Nordic Study CLL group.
Mhm.
And we have seen some studies that have reported to have collected quality of life data, but that hasn't been published or analyzed yet.
I
So a lot
see.
of studies do collect these data, but I think it's really, really important that for all the studies that we're doing, we're also collecting the data, but also publishing and sharing the data, because on the long term, I would like to have all of these data to make better treatment decisions and also inform patients about it. And also to look into not only how quality of life improves, but also when it improves. Because if there are certain treatment modalities in which the quality of life improvements are very quick, then maybe you would prefer that to other treatment modalities who possibly have the same effect on, for example, progression-free survival, and even might have the same effect on the quality of life on 2 years. But of course, if the quality of life takes a little while to improve, then the patient will have to wait for that. And maybe there are other treatment options that show an earlier improvement.
I
But for
see.
that, I will refer you to the Gaia study, because they're also starting to come out with some quality of life results, and they were able to look at that on the basis of at what time people started improving.
Yes. And I think you're right that by using validated metrics and using the same scoring system across different trials, even in different countries and different eras, hopefully we can arrive at, a common way to compare quality of life assessments across different studies. So that's wonderful. Great. Anything else that you'd like the viewers to be aware of?
Ooh, that's a difficult question. I think the quality of life is
Yeah.
is I think really important in this patient group. So I'm really hoping that we all get to study it more and also apply it in our medical practice as well.
Excellent. Well, thank you very much, Dr. Eurlings, for your time. And thanks to the CLL Society for arranging this. Hopefully this was a useful discussion.
Yes, thanks so much for inviting me, and everybody, thank you for listening.
All right, take care. Nice to meet you.